into your notes. You should not just file your rough notes. It should be used to transfer the relevant material into your notes. So the only revision material that you will have is your notes. Wherever you get information from that needs to be added, will be added to your notes. Not just adding the pages as you have written. You have to rewrite it into your notes. So your note should be completely devoid of any junk. Like if you make running notes as I am discussing, there might be things which you may want to transfer into your notes which you may not want to. There might be things which are not in a proper format. So when you finish the class, you redraft it and put it back into your notes in a neat format. So that way your notes keep getting built. Zero junk notes. Meaning your notes is something which will have everything that is to be remembered. You remember everything that is there in your notes. That's how it should be. If you are not making note of things, problem. Completed this. ECG we completed. Tell me the pathway of electricity flow. Pathway of electricity flow in the heart, starting from the beginning till the end of electricity flow. Tell me the structures through which electricity flows. Sinoatrial node. Then from sinoatrial node to AV node, how does it go? Internodal pathway. It is called internodal pathway. A pathway of fibers which is carrying electricity between the nodes from SA node to AV node. Then after that, from AV node, bundle of His. Bundle of His divides into left bundle branch and right bundle branch. Then it branches out to form Purkinje fibers. SA node is called the primary pacemaker. AV node is called the secondary pacemaker. Why? No. SA node is called the primary pacemaker and AV node is called the secondary pacemaker. Why? Two, three questions you need to further expand on this. One is this: why is SA node called the primary pacemaker and AV node the secondary pacemaker? Second, SA node produces impulses. Yes. Will AV node also produce impulse? AV node also produces impulse. That we elaborated and explored yesterday. What is the rate of impulse generation in SA node and impulse generation in AV node by itself? What will happen if there is SA node failure? Will the heart still be able to function? SA node and AV node both are pacemakers, so both are capable of producing impulses. That is clear. Both are capable of producing impulses. AV node impulse generation under normal condition is dependent on SA nodal impulse. SA node produces an impulse, gets transmitted to the AV node, then AV node produces impulse. Now if you turn on the switch for the tube light, if you turn on the switch 10 times, every time switching it off and turning it on, how many times the tube light will light up? 10 times. Every time you turn on the switch, the tube light is lighting up. But the difference is, the thing you have to remember is, it is taking a bit of time to light up. There is a delay, but the tube light is lighting up. So every time SA node fires, AV node receives the impulse and AV node also will fire with a delay. Is it clear? SA node fires, AV node also fires following that with a delay. How many times will the AV node fire per minute? How many times does the AV node fire per minute? As many times as the SA node fires. AV node fires per minute as many times as the SA node fires. Clear? If SA node influence is not there, okay, basic resting impulse generation of SA node is about 70 to 80 impulses per minute. The basic impulse generation is 70 to 80 per minute for SA node. That means for every impulse generation in SA node, there is a cardiac cycle. Because SA node will give rise to atrial systole, then AV node will fire, that will give rise to ventricular systole, then again cycle completes, start, restart. So for every firing of SA node, there will be one cardiac cycle completed. Cardiac cycle initiated and completed. Node fires at about 70 to 80 times per minute, that is the resting impulse generation for SA node. If there is no influence of SA node, independent of SA node, how many times will the AV node fire? Independent of SA node, AV node will fire, but it will fire about 50 to 60 times. Okay? So even if there is AV node, SA node failure, AV node can still maintain cardiac activity, but the cardiac output will be reduced. Why? Ventricular filling can happen only passively. Whatever passive filling can happen of the ventricles, that will be the cardiac output. Why cannot it fill completely? Because SA node is not firing, so atrium will not contract. Atrial systole will not happen. If atrial systole is not happening, then atria will not be emptied completely. If atria is not being emptied completely, the ventricles will not fill up properly, so cardiac output will be reduced. When there is SA node failure. So if SA node fails, there are questions, there can be questions. What will happen if SA node fails? If there is failure of SA node? One of the options will be the person will die because of cardiac failure, which is not the case. The right option is AV node will take over and still produce cardiac activity, still maintain cardiac activity at a reduced efficiency, 50 to 60 beats per minute. So AV node is not capable of independently producing impulses to match the demand for blood supply. When you are running, there is increased demand for blood supply, there is increased stimulation of SA node. SA node will start firing more and more. AV node can fire any number of times, dependent on SA node. If SA node is sending 100 impulses per minute to AV node also can fire 100 times. But without the influence of SA node, AV node has got no connection to the demand. The demand is connected to SA node function. Increased demand, increased stimulation of SA node fires, that will stimulate AV node can fire. AV node is a good follower. SA node is the leader who will decide how many times the firing should happen. If the leader dies, the follower will still be able to carry on the business, but not as efficiently as when the leader was alive. That's all. So, enough. Any more questions? We will see when the questions come. The figure shows the human urinary system with structures labeled A to D. Select the option which correctly identifies them and gives their characteristic and or function. So what you have to do is identify A to D and tell the function. What is A? What is A? Adrenal gland. What is B? B? Pelvis of the kidney. C? Renal? Papilla. Papilla is the base of the pyramid. It is renal, pyramid. D is cortex. D is cortex of the kidney. So there are two parts here. This outer part is cortex, the inner part is medulla. Outer part is cortex and inner part is medulla. Are there nephrons in the cortex also? Are there part of nephrons in the cortex also? Yes or no? Yes. Are there nephrons in the medulla? There are nephrons in the medulla also. Nephrons which have a significant portion of their length in the cortex also are referred to as cortical nephrons. Cortical nephrons. Nephrons which are predominantly present in the medulla are called, what do you call them? juxtamedullary nephrons. Juxtamedullary nephrons. So nephrons two types based on the position: cortical nephrons and juxtamedullary nephrons. Cortical nephrons and juxtamedullary nephrons. Cortical nephrons are present significantly in the cortex. They extend from the cortex. So because the nephrons are extending from the cortex, cortical nephrons are longer compared to juxtamedullary nephrons. Juxtamedullary nephrons are shorter. They have some functions based on their position and location. We will see that later when an appropriate time comes. But for now, just know this. So we will see what are the correlation that is given and check whether it is right or wrong. Option 1, A is adrenal gland. Is it correct? We look at only the labels. We look at only the labels to try and eliminate options. A is adrenal gland. Is it correct? B is pelvis. Is it correct? Yes. C is medulla. Is it correct? Huh? Is C medulla? D? Is C medulla? The reference looks like it is renal pyramid. D is cortex. Alright, C, medulla. Medulla is the inner zone of the kidney. It does not contain complete nephrons. Alright. See, explanations we will see. A is adrenal gland located at the anterior part of kidney. Secretes catecholamines which stimulate glycogen breakdown. Is it true? Is it true? Adrenal gland is not present in the anterior part of the kidney. It is present on the anterosuperior part of the kidney. So in that sense, okay, if not perfectly correct, it is not wrong. Part of the adrenal gland is present anteriorly to the kidney also, anterosuperior, that is superior on top of the kidney in the front part of the kidney, anterosuperior. Let us see. The pelvis is a broad funnel shaped space inner to hilum, directly connected to the loops of Henle. Is it right? So this much is correct. Pelvis is a broad funnel shaped space inner to hilum. That is correct. But it is not directly connected to the loops of Henle. It is connected to the renal pyramids ending in the renal papillin. Alright. C. Medulla is the inner zone of kidney and contains complete nephrons. I am doubtful about C being medulla. Alright. It is in the diagram it is not clearly showing. So we can still give it. We can still give it because it is extending out of the cortex. Even if we assume C is medulla, it is the inner zone of kidney, correct? Contains complete nephrons. Is it true? Even the juxtamedullary nephrons will have their glomerulus outside of the medulla. They start in the cortex. So even the juxtamedullary nephrons are extending from the cortex into the medulla, deep into the medulla. So the second part is wrong. D, cortex outer part of kidney and does not contain any part of nephrons. That is also wrong. Cortex and medulla both contains parts of nephrons. Both contains parts of nephrons. There is no, neither of them have absence of any part of the nephron. Absence of nephron. Alright. So right now, of all the four choices, of all the four options, the most appropriate one to be considered the right choice is 1. Though there is a small mistake in that, small mistake or I would say an incomplete information. Adrenal gland is not present anterior to the kidney. Adrenal gland is present in the anterosuperior part of the kidney. That's still okay. Adrenal gland located in the anterior part of kidney secretes catecholamines which stimulate glycogen breakdown. So some simple explanation is the adrenal gland, it sits on top of the kidney, not anterior but superior to the kidney. Adrenal gland secrete catecholamines such as adrenaline and noradrenaline which stimulate the breakdown of glycogen into glucose, increasing blood sugar levels during stress or emergency situations. We discussed about adrenaline hormone. What is the adrenaline hormone preparing the body for? Adrenaline hormone prepares the body for a fright, fight, flight response. Fright, flight and fight. That is the sequence. You are afraid of something. You are afraid of something. There begins the stimulation for sympathetic system. Adrenaline is produced. You want to escape it is the first option. You are afraid of something, you want to escape it. Let's say there is a hornet flying around. You see it, you are afraid of it. What will be your first attempt? You will try to escape from it, run away from it. But if it starts chasing you, what will you do? You will fight. You will try to catch hold of something that you can get your hands on and hit it. You will fight. So fright, flight, fight. Fright is the beginning of sympathetic stimulation. Flight is the first response, first option that will be explored, because in the times of danger, it is better to get away from danger. It is better to get away from danger than trying to be a hero to fight it. If there is a need to fight it, that means there is no possibility or there is no option to escape. Then fight it. Pelvis is a broad funnel-shaped space in the kidney, but it is not directly connected to the loops of Henle. Instead, it collects urine from the calyces and channels it into the urethra. Medulla is the inner zone of the kidney, but it does not contain complete nephrons. Nephrons span both the cortex and the medulla, with only parts of the nephron like the loop of Henle extending into the medulla. Cortex also is not devoid of any nephron. Cortex is the outer part of the kidney, and it does contain parts of the nephrons, including the renal corpuscle and proximal and distal carotid tubules. So the statement that it does not contain any part of the nephron is incorrect. Alright. Identification: A is adrenal gland, B is pelvis, C is medulla, D is cortex. Now just look at the structure here a little bit. Anatomy based questions are common. This is a longitudinal section of the kidney. It is a longitudinal section of the kidney. As you go from outside to inside, you have a renal capsule, very tough capsule. Likewise, you have a capsule for the liver also. What is the capsule of liver called? There is a name for the capsule of liver. Kidney and liver are very important organs. So they are covered by these capsules which protect them. Pleura is also like capsule only. All of these are coming from the same structures. So the renal capsule is fibrous. What is the name of the capsule of the liver? Capsule of the kidney is called renal capsule. Capsule of the liver is called hepatic capsule, correct? There is a name of the person who discovered it. Starts with G. Yes. Gleason's capsule. Gleason's capsule. Okay. Both are similar structures. Now you see, this outer portion is the cortex. Then you have the inner part, medulla. Inner part, medulla. The nephrons are all arranged in structures similar to a pyramid. They are referred to as renal pyramids. Renal pyramids. Alright. Then the base of the renal pyramid. The base of the renal pyramid where the collecting ducts and all join to form draining structures is the renal papilla. In between, you have what do you have in between these columns? Renal columns. Renal columns are the structures which are made up of connective tissue. There is a name for this again, columns of Bertini. Columns of Bertini. And then this region where the ureter, renal artery, renal vein are connected. The ureter and the renal vein gets out of the kidney and the renal artery enters the kidney. Is called hilum. This is the hilum portion. There are calyces, minor calyces and major calyces, which will drain the urine. Alright. So anatomy, this much. Now if the metabolic wastes are taking a pathway, they are crossing stage by stage, what are the stages they will cross to become urine? Where are the metabolic wastes to begin with? Where are the metabolic wastes to begin with? Metabolic wastes are in the blood. They enter the kidneys. Which part? They enter the kidneys, they break down and they go into the nephrons. Which part of the nephron is it entering first? Which part of the nephron is it entering first? Glomerulus. Then there is renal corpuscle, you can say glomerulus. Glomerulus and Bowman's capsule, both together are referred to as renal corpuscle. So in the glomerulus, the blood is filtered. Blood enters the kidney. Glomerulus it enters. In the glomerulus, filtration is happening. From the glomerulus, after it is filtered, it is collected in the Bowman's capsule and goes into proximal convoluted tubule. In the proximal convoluted tubule, what is the process happening? See, what is it called when it is filtered out? When all the nutrients, water, wastes, everything is filtered out of the glomerulus, the filtrate is called ultrafiltrate. Ultrafiltrate, and the process is ultrafiltration. The process is ultrafiltration. Glomerular filtrate or the ultrafiltrate. Then reabsorption in the PCT. Most of the reabsorption happens in the proximal convoluted tubule. So all the essential nutrients, all the ions, whatever is to be required, whatever is required by the body for its functioning is taken back in the PCT. Then the fluid is going down further. As the fluid goes down further, it enters the narrow tube. The narrow tube is the loop of Henle. In the Henle's loop, what happens? There is water reabsorption and ions, electrolyte reabsorption. Which part of the loop of Henle is impermeable to ions and which one is impermeable to water? The descending loop of Henle is impermeable to ions. The ascending loop of Henle is impermeable to water. Simple. In the filtration happened in the proximal convoluted tubule, lot of osmotic substances got reabsorbed. So the urine became diluted. The urine became diluted, or the filtrate became diluted. Then it enters the descending loop of Henle. Take away water. So concentration happens. Take away water, concentration happens. In the ascending loop of Henle, bring about the ionic balance. If there is a need for reabsorption of some of the more ions, take it off. Then further dilution happened. When it went to the distal convoluted tubules, in the distal convoluted tubules, further concentration by reabsorption of water, by the action of what acts on the distal convoluted tubule and the initial parts of the loop of Henle, the initial part of the collecting duct, to reabsorb water from the urine? ADH, antidiuretic hormone. There is another name for ADH. Vasopressin. So where does it act? What is the effect of ADH as vasopressin? If we look at ADH as vasopressin, what does it do? Brings about
pressure in the vasa recta.
Pressure in the vasa recta. It increases the pressure in the vasa recta, or vaso is a reference to blood vessel. Pressin is a reference to compression. Vasopressin is a reference to the hormone bringing about vasoconstriction, constriction of blood vessels. If blood vessels are constricted, what will happen to the pressure? Pressure increases. Vasopressin contributes to increase in blood pressure. Wherever it acts, it will bring about increase in blood pressure. So there are two types of chemicals that are produced in the body which will regulate blood pressure. See, regulation of blood pressure. Kidneys are closely related to regulation of blood pressure. What all can you control in blood vessels so that the pressure can be regulated? What all can you control in blood vessels to regulate the pressure? Just a small division. Kidneys are associated with two of the three processes. Volume of blood diameter of vessel, volume of blood, diameter of vessel, and the elasticity of the wall. Elasticity of vessel wall. There are three things. Now, if you look at a blood vessel, blood pressure is controlling. Blood pressure is the pressure exerted by a column of blood on the wall of the blood vessel. That's all. There is blood. There is blood vessel. Two things are there. Blood is there. Blood vessel is there. Blood is a fluid that is flowing through a tube. Through the tubes called blood vessels. Now, this tube is elastic because it has muscles in its wall. If the tube is more elastic, what is the, okay, let's say we can look at pressure in another way. Blood has to keep flowing within the blood vessels. And there is resistance offered to the flow of blood. Any fluid that flows through any tube will be faced with resistance to the flow. If there is no resistance, then the fluid will continue to keep moving forever. Correct, no? There is a resistance which is trying to stop the blood from flowing. Who is preventing the blood from flowing? What is creating resistance? What is creating resistance to the flow of blood? Blood corpuscles. Okay. Blood itself. It is a fluid. There you have given some pressure to make the fluid move. There is inertia, no? There is the weight of the fluid itself which will start pulling on the flow. The volume of the fluid. If there is more volume, now if we interpret blood pressure as the pressure that you need to create to make the blood flow, would I be right? Will I be right if I say blood pressure is the pressure that needs to be created to make the blood flow? Is it right? Correct, no? You measure the pressure in the tube. You can measure the pressure in the tube. You know how much pressure is being exerted by that blood. How much pressure is to be created is dependent on what? It is dependent on how much pressure is required to keep this blood flowing. To keep the blood flowing, you have to create pressure. Correct? It's like flow. You have candles. Let's say there is a game that you are playing. You have got 3 candles, one next to the other on a table. You have to blow the candles and will vasopressin do to blood pressure? If there is influence of vasopressin, it will cause constriction of blood vessels, leading to increase in blood pressure. So 2 factors very important. Volume and pressure relationship. Volume and pressure relationship is for the tube and not for the fluid. You talk about it, no? Volume and pressure are inversely related. It is for the tube when it comes to blood flow. So volume of the tube, volume of the blood vessel increases, blood pressure decreases. Volume of the blood vessel decreases, blood pressure increases. You have to correlate blood pressure to resistance. If there is a question asking you about what will happen to blood pressure in a particular situation, you have to think about what will happen to resistance to blood flow. If that particular situation is causing increased resistance to blood flow, then blood pressure will rise. If something is causing decreased resistance to blood flow, then blood pressure will reduce. Alright. So you can control volume of blood. You can control volume of blood by medicines. You can control the size of blood vessels by medication. There are medication that is available which will prevent sodium absorption from the kidney, which will increase sodium excretion from the kidney. So if sodium is reduced in the blood, sodium is a major osmotic substance holding on to water in blood. So if you reduce sodium, the volume of water in blood will come down, thereby reducing blood pressure. You can increase water excretion by giving diuretics. By giving diuretics which will cause excessive urination. So water is removed from the blood. Volume we are controlling. You can give vasodilators. You can give vasodilators as medication which will cause general dilatation of blood vessels, causing resistance to reduce and blood pressure will come down. But if I get a, let's say, okay, if I get a 30-year-old person in my clinic with blood pressure recording of 112, 130, I would say it's okay. Within closer to the normal range. If a person who is 60-year-old comes to my clinic and his blood pressure is around 140 to 150 systolic, I'll say it's still okay. I will not be able to reduce it below that. Why? Around 140 is normal blood pressure for an elderly person. While around 120 is the normal blood pressure, systolic, I am talking of systolic, for a young person. Why is 140 systolic blood pressure can be why can it be considered as normal blood pressure for an elderly person? There is the third factor which is adding resistance. You can control volume of blood, you can control size of the blood vessels. There is one more factor which will add to resistance to blood flow which you cannot control. What is that factor? If you consider a pipe, there are three factors influencing the resistance offered to the flow of the fluid in the pipe. One is the fluid itself, the second one is size of the pipe, and the third one is third one is what? Forget blood circulation, talk about any pipe. The third one is resistance only we are talking about. But what is causing resistance? Three factors. One is the fluid itself. Even if you consider a water pipe, the water itself is offering resistance. The size of the pipe is also offering resistance of varying degrees. What else is offering resistance? What else decides how the flow will be? Huh? Pump is an external force. Okay, I will give you three situations, A, B, C. In all the three, the size of the tube is same. In all the three, the size of the diameter of the tube is same. The fluid flowing through all the tubes is the same. The power of the capacity of the motors connected to this is the same. And all the three are running for the same duration. All the three are running for the same duration. And all of them are supposed to pump 500 liters of fluid. All the three are supposed to pump 500 liters of fluid. As soon as 500 liters of fluid is pumped out, the respective motors will shut off. There is an auto shut off initiated for the motor to shut off as soon as 500 liters of fluid is pumped out. So you have set the experiment. You turn on all the three motors at the same time. All the three motors will turn on at the same time because all of them are connected to the same switch. After 500, there is internal cutoff at every motor. So turning off will be individual. Turning on is same at the same time. You turn on one switch, all the three motors have started. If I tell you all the three motors did not shut off exactly at the same time, why would that be?
So the length is different.
Length of the pipes also same. Same diameter tubes, same length tubes, same fluid is flowing through all the motors, all the pumps, all the pipes. The capacity of all the three motors same. All the three motors are pumping 500 liters of water. All of them are turning on at the same time, but all of them did not turn off at the same time. That means each of them took different times, different duration to pump 500 liters of blood, 500 liters of water. Why?
Thickness of the pipe.
Hmm?
Thickness of the wall of the pipe.
Thickness of the wall of the pipe is also same. You are thinking right. You are thinking right. You have to think something else. Pressure is the same because all the three motors are of the same capacity.
Nature of the wall.
Huh?
Nature of the wall.
Nature of the wall. Elaborate. Okay, you mean to say all the three pipes are made up of different material?
Due to age, the wall become more elasticity. Elasticity.
Huh? Elasticity of? Elasticity of, see, by nature of the wall, okay, I will say all the three pipes are of the same age. All the three pipes are of the same age. Now what? You all got closer and you went away. I even tried to put you on the right track, you refused to get on it. Well, no, I'll come walking. Alright. Come on, think, you're all there. Otherwise you will have your moment now. Come on. If the three pipes are made up of different materials, is there a possibility that the outcome I told could happen? If the three pipes are made up of different materials, let us say one pipe is made up of rubber, another pipe is made up of plastic, and the third pipe is made up of steel. Keeping the thickness of the wall, the length of the pipe, the diameter of the pipe, pressure of the pump, everything same. Is there a possibility that the time taken by each of these pipes to pump 500 liters of water be different? No? It won't be different? Will it be exactly the same?
So there might be accumulation in the pipe on the side.
There might be accumulation in the pipe. All the pipes were empty to start with. Does the elasticity of the wall contribute to the resistance of flow, resistance to flow? Does the elasticity of the wall of the tube, contribute to the resistance to flow, or influence the resistance to flow? Pressure is being exerted on the fluid. The fluid has to use that pressure and flow. Yes or no? The fluid has to use that pressure and flow. But will the pressure remain intact in the fluid, or will the pressure get dissipated? The fluid is flowing and the fluid also is hitting the wall. No? The fluid is coming in contact with the wall. That means the pressure is trying to push the wall also. The pressure is trying to push the wall as well. If the wall is elastic, what will the wall do? It will push the fluid back, not allowing the pressure to get dissipated. It will just push it back so that the pressure is put back into the fluid. If the wall is stretchable but not elastic, is there a possibility that something is stretchable and not elastic? Is elasticity and stretchability the same? No. Elasticity is the ability to get back to its original position. Even distorting force is opposed, and the elastic material tends to get back to its original position. That is elasticity. No. Stretchability is distortion. The shape gets distorted, the structure gets distorted because of the force. So rubber is elastic or stretchable. Between of all the three, rubber, plastic and steel, which one has more elasticity? Huh? Rubber has more elasticity. Huh? You have to go back to your physics books for that. Talk to your physics teachers for that. But with my logical understanding, rubber has the least elasticity. Rubber is least elastic. Rubber is not more elastic. I think steel is most elastic. Steel is more elastic than plastic, which is more elastic than rubber. So in this case, I feel steel pipe will pump 500 liters first, then followed by plastic, and last will be rubber. The difference may not be very big for 500 liters, but even if you start calculating milliseconds, there will be difference. But why am I telling you this? The third factor which will influence resistance. If a person with 145 or 140, 160, 140 blood pressure, who is an elderly man, 55, 60-year-old, I say it's normal, it's okay, let us not try to reduce the blood pressure below that. Why is that? The blood vessel wall is elastic. With age, the blood vessel wall becomes rigid. Rigidity of the blood vessel wall will add more resistance to blood flow, thereby increasing the blood pressure. The baseline of what normal blood pressure is increases as age progresses. So a 60-year-old, 70-year-old person coming to you with 140, 150 blood pressure is not a concern for you. If a 20-year-old comes to you with 150 blood pressure, then there is something wrong. You have to figure out why it's happening. You understand three factors which influence blood pressure. What are the three factors? Volume of blood flow. Second one is the diameter of the blood vessel. And the third one is the elasticity of the blood vessel wall. Three factors. Anyways, volume of blood flow, kidney can regulate. Kidney also has contribution to regulating the vessel wall thickness by providing receptors for the influence of vasopressin. Kidney will regulate the volume of blood by regulating the excretion of sodium and water. Correct? Okay. So these structures that it will pass through, see, this is the sequence, this is the summary of the path of travel for metabolic waste. From the blood it comes into the glomerulus. This you should know, the sequence. When we are learning, when we are reading, it all appears very simple. But when it comes to the exams, in the examination setting, small things, simple things can go wrong. Okay. So always sequences, what comes after what, all those things should be very clear, repeated revision. So from blood, glomerulus, in glomerulus filtration happens. In Bowman's capsule, proximal convoluted tubule, reabsorption. Loop of Henle, concentration. DCT, reabsorption and secretion. After DCT, it goes into the collecting duct. From the collecting duct to the renal pelvis to ureter, ureter to urinary bladder, then urethra. There are structures in between also. Alright. But get the gross ones, the major ones. Mixing up of the sequence should not happen. Structures from nephron to urethra. Remember the structures from nephron to urethra. Continuity, in continuity. I told you the flow of fluid, what it passes through. Now we will see what structures are there which we can trace continuously. In the nephron, Bowman's capsule, proximal convoluted tubule, loop of Henle, DCT, collecting duct. Collecting ducts will go into the converge together to form the renal pyramids. Renal pyramids will come together at the tip of the renal pyramid to form the renal papilla. It goes to the next level. The base I told you, no? The tip, the base is the renal papilla. Renal pyramid to renal papilla. From there, from the renal papilla, urine is drained into minor calyx. From minor calyx, it goes into major calyx. From major calyx, it goes into the pelvis, then ureter, then urinary bladder, urethra. Alright? See, this is important. Pathway. The pathway for the flow of filtrate eventually becoming urine. Even if we consider ultrafiltrate as the initial stage of urine, remember the pathway for the flow of urine. Important. You will not go wrong on clear-cut conceptual things. Either you have understood or you have not understood. If you have not understood, you can somehow deduce also. You can arrive at some answer. But when it comes to sequences, structures, lists, right. Okay. This sequence is important. When the time is right, I will give you something called the advantage manual. Alright. You have to finish before that all the basic things that you have to learn. About 100-150 pages of advantage manual will help you get some advantage in the exam. Will help you avoid pitfalls, where you might fall, where you might go wrong, confusing things, those things. But before that, you have to complete all of that I told you to complete. We have not gone into the physiology of the renal system, we have just touched upon the structures. Now, can you recall the structures? Visualize the kidney. Alright? We go from outside to inside. You have to peel off the kidney like a bean. What is the covering for the bean called? Renal capsule. You open the bean, you open it up. On the outside of on the outer part we have cortex. On the outer part we have cortex. Then you will start seeing the nephrons being bundled up into structures called renal pyramids. At the base of the pyramid, it will narrow down to form a tip that is called renal papilla. From the papilla, you will find small tube-like structures, small tube-like structures connecting to multiple papillae. What is that? Minor calyx. That will join together to form major calyx. A few major calyces will open into pelvis. Pelvis continues into the tube, ureter. Ureter opens into urinary bladder. From there it is urethra. That's all. That visualization you need to have. Next. Select the correct statement with respect to locomotion in humans. A decreased level of progesterone causes osteoporosis in old people. Here, locomotion is what we are discussing. There is connection of progesterone, osteoporosis, uric acid, vertebral column, adjacent vertebrae, fibrous joint. So there are so many concepts associated in this chapter, in this question. Connection of progesterone to osteoporosis. Is there a connection of progesterone to osteoporosis? No. Why progesterone has been given in this question, in this option? Huh? Estrogen has connection with osteoporosis. Estrogen is the female hormone. Estrogen is the female reproductive hormone. Estrogen is said to have osteoprotective effect. It promotes mineralization of bones and it counteracts the effect of parathormone. Estrogen counteracts the effect of parathormone, or it prevents parathormone from scraping off bones. So estrogen protects the bones of females. That is why menopausal age, post-menopause, women are supposed to be given calcium supplements. Calcium supplements because withdrawal of the influence of estrogen, protective effect of estrogen, will make the effect of parathormone more active. So far it was not allowed to act properly because estrogen was blocking it. Now estrogen is removed. Parathormone can start increasing the resorption of minerals from the bones. So calcium supplementation will take care of that. Post-menopausal women should take calcium supplementation. During the reproductive years of the lady's life, bone is protected. Osteoporosis, I told you already, we have already discussed. Osteoporosis is softening of bones because of demineralization, removal of calcium. Minerals are being removed from within the bone. That makes the bone porous or soft. Osteoporosis. So, first statement is wrong. Accumulation of uric acid crystals in joints causes their inflammation. First of all, uric acid, is it present in blood? Do we have uric acid in our blood? If we have uric acid, where is it coming from? Why is it getting accumulated in the blood? If it is getting accumulated in the joint, if at all it is getting accumulated and causing inflammation, what will happen under normal circumstances? Will it not get accumulated in the blood? What is happening during normal circumstances? Because if it is getting accumulated in the joint space and causing inflammation, that means normally it is not accumulating. Therefore, normally it should not be left in the blood without metabolizing. Somebody is metabolizing it. So all that we need to explore. What all can you answer in that? Is uric acid present in human blood? Do we have uric acid in our blood? Normally, do we have uric acid in our blood? No. Is presence of uric acid in the blood abnormal? Is presence of uric acid in the blood abnormal? Yes or no should be the answer. Okay, some of you are saying yes. Where is uric acid produced from? What is uric acid produced from? Where is it coming from? Where is it coming from? Liver metabolizes uric acid. Uric acid is a byproduct of protein metabolism. Uric acid is a byproduct of protein metabolism. When you eat excessive proteins, meat and other excessive proteins, uric acid will be produced in larger number. Uric acid, urea, uric acid, all of these are present in the blood in normal conditions also. They are present within the normal range. They are a byproduct of protein metabolism. Now, either because of excessive consumption of proteins coupled with decreased metabolism of uric acid, there is a possibility of uric acid remaining in the bloodstream. When uric acid remains in the bloodstream at a quantity at a concentration more than what it is supposed to be, beyond the normal range for a long period of time, it can get into the synovial space of joints. Joint space it can enter. Because synovial fluid is present in the joint space. In the synovial joints, a fluid is present which we call the synovial fluid. That fluid is constantly being produced and regenerated. There is vascularity in the synovial membrane also. That is, there is blood supply to the synovial membrane. Synovial fluid will have accumulation of some toxins also that will be removed. So there is exchange of material between the blood in the synovial membrane and the synovial fluid. So with accumulation of uric acid, what will happen? It kind of scratches your skin and it irritates your skin. Uric acid also is like that. When it becomes crystalline, it becomes kind of hard and starts rubbing the inside of the joint space. When it rubs the inside of the joint space, it will irritate the joint space. Any irritation will be identified as injury by the body's immune system. And the immune system will start trying to attack that uric acid and try to remove it. And any attack of the immune system for the purpose of removing infection or injury is seen in the form of inflammation. Correct now? This is the story. Uric acid metabolism in the liver becomes disrupted. It becomes less efficient. That makes uric acid slowly become more and more in concentration in the blood. With increased uric acid in the blood, uric acid will start entering into the joint space. With more and more uric acid coming into the joint space, it will start forming crystals. It will crystallize. You add more and more salts, dissolved salts. You dissolve salt in water. You let the water be like that for many days. Will not the salt also in water start slowly crystallizing? You will find some salt deposits at the bottom. Initially it was dissolved, but gradually it will start settling down. So that crystallized uric acid will start irritating the joints, causing inflammation. Inflammation of the joint will lead to pain. Inflammation of the joints is referred to as, what is the technical term for the inflammation of the joints? Good morning. Wake up. Go wash your face. What is inflammation of the joint called? Arthritis. Arthrosis is joint. Arthro refers to joints. Itis refers to inflammation. Arthritis. This arthritis, because of inflammation of the joints due to deposition of uric acid crystals, is called gouty arthritis. Gout, G-O-U-T, gout is the disease. Gout is the disease caused due to accumulation of uric acid crystals in the joint space. So second statement is correct. Third one, the vertebral column has 10 thoracic vertebrae. Yes or no? How many vertebrae are there in the vertebral column, thoracic vertebrae in the vertebral column? 12. What are the different regions of the vertebral column? Segments. This is. Tell me the segments of the vertebral column. In the neck, corresponding to the neck is cervical, then thoracic, then lumbar, sacral, coccygeal. Alright, these are the segments. In the thoracic segment, you have 12 vertebrae. The thoracic segment, you have 12 vertebrae. Each vertebrae forming a joint with the posterior end of the corresponding rib. Each vertebrae having joint with 2 ribs, one on either side. The joint between adjacent vertebrae is a fibrous joint. Now here you need to know what a fibrous joint is. Is it a fibrous joint? What do you mean by a fibrous joint? Fibrous joints are immovable joints. Okay? Joints based on their mobility are either immovable joints, they don't move at all, they are permanently fixed. Fibrous, there is fibrous tissue in between the 2 bones. They can be partially movable joints, cartilaginous joints. They can have cartilage in between which will allow for partial movement. And there can be mobile joints, joints which have a good amount of mobility with the space between the bones and the fluid in between within the space. Those joints are called movable joints or synovial joints. Synovial joints. Is the intervertebral joint between adjacent vertebrae is intervertebral joint. Is it permanently fused? Fixed? No. Is it freely movable? No. It is a partially movable joint. Partially movable joints don't have fibrous tissue. It is not a fibrous joint. It is a cartilaginous joint. So statement 4 is also wrong. What is correct is only uric acid crystals in joints causing inflammation. So just read the explanation and all the descriptions, which will help you. Which will help you understand. Accumulation of uric acid crystals in joints is a condition known as gout. Gout leads to the formation of sharp uric acid crystals in the joints. I told you it will start irritating, rubbing against the joints, causing inflammation, pain and swelling. This condition is common in joints like the big toe, knees and ankles. So if you have people coming to you with increased pain, arthritis of the knees, ankles and great toe, big toe, likely that they might have gout. You should look for swelling of these joints. You should look for redness on the joint. Alright? And you should look for deformity. Gout causes deformity of the joints. If inflammation will start causing deformity of the joint becomes deformed. Alright? Why other options are included? Increased level of progesterone causes osteoporosis in old people. It is because of estrogen, not progesterone. I told you, decrease of estrogen during menopause will lead to osteoporosis. Vertebral column has 12 vertebrae, not 10. Joints between adjacent vertebrae is a fibrous joint, wrong. This joint between adjacent vertebrae are cartilaginous joint. I told you, especially symphysis, which allows for limited movement and provide cushioning between the vertebrae. Okay, I have given some bones. You can remember all the bones, it's easy to remember, no problem. Skull has how many bones in total? Skull alone, 22 bones. Skull has 22 bones, not one bone. All the bones fused to each other, fibrous joints. Alright. Vertebral column. Vertebral column has how many bones? 26. 26. But in those 26, sacrum is considered one bone and coccyx is considered one bone. But sacrum is made up of 5 bones fused together to form one unit. Coccyx is made up of 4 bones fused together to form one unit. So in that sense, if you look at it, 4 plus 3, 7 more, 33 is the total number of bones in the vertebral column. 33 is the total number of bones. There are 26 units of bone, that is 26 bones that you can separate. Sacrum 5 fused together to form one. So skull, cranium has these bones: frontal, parietal, temporal, occipital. This is no problem. Frontal, temporal, parietal, occipital. Then you have mandible, maxilla. Mandible, maxilla. This much is clear. You should not have any confusion. Then you have the small bones. Zygomatic bones, this one. This bone is the zygomatic bone. This is called the zygomatic arch bone. Alright, this bone here, zygomatic bone. Zygomatic arch forms part of the orbit. Then you have lacrimal bones here. Lacrimal bones is here, inside of the orbit. Then you have palatine bones, which forms the upper palate. The hard bony palate. Palate is upper only, which forms the bony palate. Vomer, inferior nasal concha. Vomer is inside the nose. Inferior nasal concha and vomer are inside the nose. Alright. There are few more bones at the base of the skull. Sphenoid and ethmoid bones are at the base of the skull inside. Sphenoid, ethmoid. Alright. Vertebral column, 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar, 5 sacral, 4 coccygeal. 5 sacral fused to form 1, 4 coccygeal fused to form 1. Question here can be a bit confusing. How many bones are there in the vertebral column? If you have 26 and not 33, choose 26. If you have 33 but not 26, choose 33. But if you have both, 26 and 33, what do you choose? 26. Choose 26. Because generally in the exam when the number of bones in the vertebral column is being asked, it is generally the reference to individual bones. Specifically the question might be how many bones fuse together to form the sacrum. Then it is fine. Then you have, see, skeleton is again 2 types of skeleton. Okay. Axial skeleton and appendicular skeleton. Axial skeleton is what is at the center of the body, not having double. Okay, appendicular skeleton is limbs. Appendix is attachment. Appendix means attachment. Appendage means attachment. So appendicular skeleton is the skeleton that forms the attachment to the body. What are the attachments? The upper limbs and the lower limbs are the attachments to the body. So shoulder girdle, you have clavicle. Clavicle, this is the clavicle. Collarbone. Clavicle is also referred to as the beauty bone. You know that? Clavicle is called the beauty bone. So, why beauty bone? I don't know. As one starts becoming more and more obese, it will get masked. It will cover off. Maybe that is the reason why it is referred to as beauty bone. So, if it is visible, then you are not yet obese. Scapula is referred to as shoulder bone. Upper limb you have humerus, that is the arm. Radius, ulna. Radius is on which side? On the side of the thumb or on the side of the little finger? Which side is radius? Thumb or little finger? Which side is radius? Sure? 50% chance. Sure? On the side of the thumb, this side, laterally is radius, this is ulna. Alright? Similarly, in the leg, you have tibia, fibula. Tibia is on the inner side, on the side of the great toe again. On the inner side, fibula is the opposite. Tibia, fibula is different, small. Shin you feel, no? You feel the shin. The bone, the muscle-less part on the anterior part of your leg, here. You feel bone here. What you call as shin. In front you have no muscle. You will feel the bone under the skin directly. Correct? That is the tibia. Where is the tibia? That is what you hit when you don't move properly. You hit it to something hard, pains a lot. Alright. Then you have, ulna, forearm, pinky side. Oh, you saw that, huh? Alright. Wrist has carpal bones, metacarpal bones and phalanges. How many carpal bones are there? 8 carpal bones. The difference between upper limb and lower limb. Corresponding structures you should see. Upper limb, what is humerus? In the lower limb, that corresponds to femur. In the upper limb, radius corresponds to tibia. Upper limb, ulna corresponds to fibula. Tibia, fibula. Here, the palm, base of the palm is carpal bones, 8 in number. In the foot, you have tarsal bones, TARSL, tarsal bones, 7 in number. 7. Metacarpal bones. Metacarpal bones are 5 in number, each hand. Metacarpal bones here, below the base of the finger, at the base of the finger. At the base of the palm, you have carpal bones. You have 8 bones here. Metacarpal, 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 metacarpal. 5. Similarly, in the foot, you have metatarsal. How many? 5 metatarsal. And phalanges, each bone in the fingers. How many phalanges are there in the thumb? 2. In the rest of the fingers, you have 3. 1, 2, 3. So 14 in each hand. Similarly, phalanges 14 in each foot. So we have the same number of bones, correct? How many bones are there in this one arm? One limb? 1, 2, 3, 8, 11 plus 5. 11 plus 5? 16 plus 14. 30, 1, 2, 3, plus 8, 11, 5, 16, plus 14, 30. 30 plus 30, 60. But in the lower limb, everything was corresponding except 7 each of metatarsal. So in the lower limb, it would be corresponding structures 58. But there also you have 60 bones. Which are the other two? What is the bone that is present in the lower limb which has got no corresponding bone in the upper limb? Patella. Patella is the kneecap. So number of bones is same. There again. Pelvic girdle or the hip bone, 2 are there. Hip bone, pelvic girdle or the hip bone. There are 3 parts in that: ilium, ischium, pubis. Okay, done. That's all here. Number of bones you see. There are 3 small bones inside the ear, also in the middle ear. What are the 3 bones in the middle ear? Huh? Malleus, incus, stapes. Malleus, incus, stapes. 3 bones. Of the 3, which one is the smallest? Stapes is the smallest. So the smallest bone in the human body is stapes. So, shoulder girdle, humerus, every bone we have listed here just for reference. Sometimes the question is based on numbers. Totally there are 206 bones in the skeleton. 206 bones, 199 units of bones. Alright, 206 bones we are considering with sacrum being 5 and coccyx being 4. If you consider that to be 1 each, then it is 199. Alright? Okay. Done. Joints I have not given here because we have a question on joints. So we will discuss joints in the next question. Is this clear? Skeleton, do you understand now? Gout we understood, arthritis we understood. There are different types of arthritis that one can experience. Gouty arthritis is because of uric acid crystals. Rheumatoid arthritis is because of what? Another arthritis about which question comes. 3 types of arthritis you will have to remember. Gouty arthritis is one because of it's a metabolic disorder. Then osteoarthritis can be because of bone infection. Osteoarthritis can be because of some bone infection. Rheumatoid arthritis is autoimmune disorder. Rheumatoid arthritis is an autoimmune disorder. That means the body's immune system is identifying the joint as a foreign body and attacking it, causing inflammation. There is an autoimmune disorder of the skin, melanocytes, melanin producing cells, causing depigmentation of the skin. What is that? That is also an autoimmune disorder. Starts with V. Vitiligo. Right. So we will see when we get to some question which talks about autoimmunity, we will elaborate a bit more on that. Move further. Now, Characteristics and an example of a synovial joint in humans is fluid cartilage between two bones, limited movements, knee joint. See, characteristics. What is the joint is mentioned. What is the characteristic is mentioned, and an example is mentioned. So we need to know details of the joints to be able to answer this question. You need to know what are the types of joints, how do we identify a particular type of joint, what will be the articular surfaces. Articular surface means what? How will the surface of the bones participating in the joint be? Is synovial joint a fluid cartilage between two bones? In synovial joints, there is fluid, correct? But in synovial joint, there is no cartilage between two bones. There is fluid between two bones. Okay, so cartilage between the bones is another type of joint, cartilaginous joint, which is not synovial joint. So this part is wrong. Limited movements. Limited movements is still okay. Not all synovial joints have full range of movements. The range of movements will vary. So that is still we can give benefit of doubt. Knee joint is an example of synovial joint, but there is no cartilage, so this choice is wrong. This cannot be the wrong. This cannot be the right choice. Okay, we need to come. Okay. Now second option, fluid filled between two joints. Fluid filled between two joints. Is the synovial joint the fluid between two joints? Is it the fluid between two joints? It is between two bones, not between two joints. Joint is the space between two bones. Alright, it is not between two joints. Provides cushion. This is correct. The fluid provides a cushioning effect. Skull bones is not correct. Skull bone is not synovial joint. Skull is fibrous joint. Skull is fibrous joint. You can do this on your question paper. You can write on your question paper when you are attempting the exam. You can write on your question paper. So, part by part you eliminate. This is not possible. This is not possible. This is not possible. Fluid filled synovial cavity between two bones. Fluid filled, correct. The space is called synovial cavity. It is between the two bones, correct. Joint between atlas and axis. Now here you need to know the types of synovial joints. The description of synovial joint is clear. But is this joint a synovial joint? If you know, you know. If you don't know, let it be. Let it be. Alright, check the next one. Limb filled between two bones. Limited movement, gliding joint between carpals. Here again, you are not sure about the example, let us assume. Is it lymph that is filled between the two joints? The fluid in the joint space is not lymph. It is a special fluid, synovial fluid. So lymph is wrong. Even if you don't know the examples of joints, you should still be able to answer this question. You should still be able to answer this question by partial elimination of the wrong things. So, fluid filled synovial cavity between two bones is the description of a synovial joint, and the joint between atlas and axis is a synovial joint. But what kind of joint is that? It's a pivot joint. It's a pivot joint. We'll see the different types of synovial joints. Is this clear? Analysis is clear. Why do you have to consider something to be the right choice? Same things that we discussed, I have given in writing. Gliding joint is correct, but it is not this. Joints are classified on various parameters. There are multiple bases on which joints can be classified. Based on what is in between the bones. How are the bones coming together with each other? You have three types of joints. Fibrous joints, cartilaginous joints and synovial joints. We already discussed. Fibrous joints, what will you have in between the bones? Dense connective tissue, mostly collagen fibers. What is in between, what is it made up of? Collagen fibers. Where do you find it? Sutures. Syndesmosis is fusion of joints at their end. Fusion of bones. Syndesmosis is between the tibia and fibula. Gomphosis is also similar. Alright. Gomphosis is like a peg fixed into a base. Tooth in the socket is gomphosis. Alright. Cartilaginous joint, made up of cartilage. What do we have in between the two bones? We have cartilage in between the two bones. Generally, hyaline cartilage or fibrocartilage is present in between the two bones in cartilaginous joint. Different types of cartilages also you have to make note. Have you made note of it already? While making your level 1 notes. Different types of cartilage. Hyaline cartilage or fibrocartilage. Intervertebral joints, that is the joints between the vertebrae, is cartilaginous joint, except one intervertebral joint, that is between 1 and 2. Vertebra number 1 and 2, atlas and axis. The joint between those two vertebrae is not cartilaginous joint, it is a synovial joint. If you notice, the movement, maximum movement in the vertebral column is present only at the neck. That is happening because of the atlas and axis joint. Alright. Cartilaginous joint is present in the pubic symphysis. Pubic symphysis is where we have three parts in the pubic bone: ilium, ischium, pubis. So this is the pubic bone. This is what is at the front. This is the bone at the front is the pubis. The junction between those two bones, fixing the two pelvic bones to each other, is the pubis. The junction is called pubic symphysis. Joint between the first rib and sternum. Joint between the first rib and sternum is also cartilaginous joint. Alright. Next, synovial joints. What do we have in between the bones? Synovial cavity filled with synovial fluid, surrounded by a fibrous joint capsule. Surrounded by a fibrous joint capsule. See, now here there is a problem. Fibrous joint, no problem. The bones are close to each other. You have fibrous tissue in between. The bones remain fused. So there is no gap. You don't have to stabilize this joint. This joint is stable. This joint is stable, like the skull. You don't have it. You have joint, but the joint is fused. So there is stability. No space gives stability. Space gives mobility. Between stability and mobility, you have to play. In the skeleton, there are two things only, no? You need to have stability as well as mobility. Wherever you don't need any mobility, go for absolute stability. Use the bones. Where you need mobility, you need to have space between the bones. Then the problem of stability comes. How do you provide stability? There are bones here. Bones are at a distance from each other. There is a gap between the bones. Gap filled with fluid. To prevent the fluid from escaping, you are providing a capsule. You are just tying it up. You are just surrounding it with a capsule to prevent the fluid from escaping. How do you provide stability? This is unstable. It can just slip off. It can deform. How do you provide stability?
So tendons and ligaments.
Ligaments. Ligaments are for stability. Tendons are for fixing the muscles. Though tendons, because they fix the muscle to the bone, also contribute for stability because Muscles will provide counter forces. There are extensors and flexors. Opposite acting muscle groups are present at every joint. Opposite acting muscle groups are present at every joint, which will hold them together. Hold. Reduce blood supply, recovery delays. Correct? For any injury to recover, you need to have possibility of repair material reaching the site of injury. If the repair material cannot reach a particular site of injury, the repair cannot happen. Recovery cannot happen. Among all the connective tissues that you have in your body, the least amount of blood supply is for ligaments. So ligaments have a very important role of giving stability to the joints. Ligaments have least amount of blood supply. Any ligament injury will lead to an extended duration of recovery. Why will ligament injury happen? Over forceful stretching of the joints. Stretching of the joints beyond the range provided by the ligaments will make the ligaments get torn or injured. Okay. Ligaments are elastic compared to tendons. Tendons and ligaments are very crucial at the joint space. Tendons are attaching muscle to the bone. Ligaments are stabilizing the joint. Tendons are not elastic. Tendons don't stretch. They just transmit the force to the bone. Ligaments are elastic. They stretch. So ligaments will allow for range of movements, graceful movements, smooth movements. Alright? Human beings moving their body parts is because of ligaments. If ligaments were like tendons, we would be moving like robots. Jerky movements. A particular movement hitting its limit, next movement begins, hitting its movement, limit, next movement begins, hitting its limit. Flow of movement is possible because of ligaments. Yes, sir.
So, what about ACL, sir? Injuries with ACL?
Any injury, whether it is anterior cruciate, posterior cruciate, medial ligament, whatever is the ligament injury that happens around the knee, it will take its time to recover. Okay. A whole range of ligaments are there. All right. We'll see what all we have. There are technical names: synarthrosis, amphiarthrosis, diarthrosis. Synarthrosis, if you get a term synarthrosis, it is a reference to fibrous joint. Synarthrosis means fused, immobile. Amphiarthrosis means partially mobile joints, and diarthrosis is freely movable joints. It is the same as fibrous joints, cartilaginous joints, and synovial joints. Classification of synovial joints. I will show you a diagram. You see this ball and socket. Ball and socket joint, like our major shoulder joint and hip joint. Ball and socket joint. This is hinge joint, like the hinge of a door. Like the hinge of a door opens and closes in one plane. This is between the metacarpal and carpal and metacarpal. You see this? What does this appear like? I'll try some drawing, okay? is this? Huh? Oh, you can make out. Horse. So what is this on the horse's back? Saddle. What is this joint? Saddle joint. Where one of the articular surfaces will appear like a saddle of the horse's back. Okay, between the carpal, trapezium and metacarpal. So this is saddle joint. Now here what do we have? It's like this thing. Pivot. Something being fixed into another and it rotates around that. A joint where one bone rotates around another bone. One bone rotates around another bone. Fixing. Here you see this atlas and axis. I told you atlas and axis. Atlas is the first vertebral bone and axis is the second vertebral bone. The extension, the projection from axis is going into atlas. That is what will allow us to move our neck. Rotational movement of our neck. That is pivot joint. This is condyle. Condyle means, you see here, there is a circular surface on one side and a narrow or not so deep plane on the surface around which it moves. It is not a socket, but it is like a shallow plate. Condylar joint. This one you see, this is the clavicle and this is the acromion process of the scapula. Between the clavicle and the scapula, both the surfaces are flat. Both the surfaces are plane. So these kind of joints are called planar joints or gliding joints. Gliding joints. Now you see this. Start from here. You have a gliding joint where both the articular surfaces are flat. Why this gliding joint is helpful here? When the clavicle is attached here to the acromion process of the scapula, when we move this, when you do this movement, the shoulder blade is also moved a little bit. It is not fixed firmly in its position. It can move, allowing you to bring about this movement. When you do this, shoulder blade gets pushed backwards. Around the at the junction, at the joint here between the tip of the clavicle and the acromion process, there is sliding of the joint, there is sliding of the bone, allowing you to do that movement. Otherwise, imagine if the shoulder blade was fixed in its position and clavicle was fixed in its position, this and this movement would not have happened. Alright? So you have gliding. The bones will glide over each other. This is the clavicle, this is the scapula. When you flex your elbow, it will slide like this. When you extend your elbow, it will slide like this backwards. Understand? Now next, come to the condylar joint between the metacarpal and the phalanges. Metacarpal and the phalanges here, this joint. This is the metacarpal bone and this is the phalange. One of it becomes a little curved to allow for the curvy surface of the other bone to move on it. You see this? This is possible. This is one joint I am moving here. Alright. So this is the joint. What joint is this? Condylar joint. This is possible. This is possible. This is also possible. This is also possible. Correct? Condylar joint provides the joint reasonable stability that a ball and socket joint provides. Not as much as that, but it provides good range of movement. Good range of movement. So you can do it in any direction. Ball and socket also allows you good movement and it gives you better stability. Condylar joint and ball and socket joint are similar in the way it provides you range of movements. But ball and socket is a more stable synovial joint because you are holding the articular surfaces more strongly. Alright. So we have three joints, one in continuity with each other. planar joint or the gliding joint, first one. Then you have this articular surface becomes a little bit curved and you have a curved another articular surface. This is condylar joint. Then ball and socket joint. Three joints are easy to remember here. One is the pivot joint. You have the horse's back saddle joint and elbow and knee hinge joint. 6 joints. Major joints you should remember. Examples will be questions in this topic. All the major joints and what type of joints they are, I have given you in this table. This table should help you remember what joints are present where. So hinge joint, what do they? Hinge joint will allow you to do one plane movements, uniaxial, one axis, flexion, extension. Same with knee also. Okay. Elbow, knee, interphalangeal joints between fingers and toes. This also you see. You can't do this here. You can do this. You can stretch out your fingers. You can stretch out your digits not because of the interphalangeal joints. It is because of the condylar, metacarpophalangeal joints. It is because of the condylar metacarpophalangeal joints that you are able to do this. This is possible. Alright. This one is also happening here. Can you do this in any of these intervening joints? In the digits, they are hinges. They will act in one axis. Alright. See here, if you do just this much, so much is happening. Alright. Hinge joints in play, gliding the condylar joints in play. At the wrist you have saddle joint here. Okay. Anyways, ball and socket joint, multi-axial movement, multiple axis, flexion, extension, abduction, adduction, rotation, circumduction, everything is possible. Pivot joint, rotation around a single axis. Rotation around a single axis, that is also single axis rotation. Joint between atlas and axis vertebrae. C1, C2. Saddle joint, flexion, extension, biaxial. Joint at the base of the thumb between trapezium and first metacarpal. You do this here. You can feel it here. Can you do this? Like taking your thumb inside, making your thumb dance. Two axis movement is happening here. Saddle, this is the saddle joint. It is allowing you to flex and extend, abduction and reduction. Inward, outward, inward, outward, inward, outward. Okay. Flexion is bending at the joint. Extension is opposite. Abduction is taking away from the central axis. Adduction is coming closer to the central axis. So this is abduction. This is adduction. This is abduction. This is adduction. Okay, abduction, adduction. Thumb. This one. The saddle is also contributing for that. Condyloid joint or ellipsoidal joint. Flexion, extension, abduction, adduction. Biaxial movement. Wrist joint between radius and carpal bones. Here. You can do this also. You can do this also. You can do this also. Why? This is two axis joint. Two axis joints. Condylar joint. Mandibular joint. This is one axis. You can do this also. Condyloid joint will allow you two axis movements. Two axis movements. This. Okay. Plane joint, gliding joint, non-axial, they don't have access. Multi-axial position is, multi-axial movement is possible on gliding joints. sliding or gliding movements, intercarpal joints between carpal bones in the wrist, intertarsal joints between tarsal bones in the foot, scapular and clavicle joint between scapula and clavicle. See here also, there are 8 bones here. There are 8 bones here. Because of the gliding nature of the joints, you can cup your palm. You can cup your palm. Alright, cupping of the palm requires so many things to happen. There is flexion happening at all of these joints. Metacarpophalangeal joint. What type of joint is metacarpophalangeal joint? Between the metacarpal and the phalanx. First phalanx. 2 axis. Would say what is it? Condyloid joints. Alright. So flexion here. Here you have abduction here in the trapezium and the metacarpal of the thumb. Then all these bones of the carpal bones are sliding over each other to form this cup. Cupping of the palm is possible because of 8 bones sliding over each other in a very regulated manner. Alright? Done. Is it clear? Can we recall joints now? Synarthrosis means what? What is the range of movement possible in synarthrosis? 0. No movement possible. What is amphiarthrosis made of? What is amphiarthrosis made of? Cartilage. Amphiarthrosis is cartilaginous joint. Range of movement? Limited. Very limited range of movement. The fluid filled joints are called? The fluid filled joints are called? Synovial joints. The fluid filled joints are called synovial joints. How many types of synovial joints are there? 6 types of synovial joints are there. Circular axis is provided. Present in which type of synovial joint? Movement around the axis is possible in which type of synovial joint? Movement around an axis. Movement around an axis. Pivot joint. Movement around an axis is pivot joint. What is the joint that will allow for what is the synovial joint which has maximum stability? Ball and socket joint. Ball and socket joint. Joints in the palm of the hand between the carpal bones. Gliding joints. Gliding joints. On the basis of joints, pick the odd one out. On the basis of joints, pick the odd one out. Elbow, knee, interphalangeal joints, and shoulder joint. Shoulder joint. Shoulder joint is ball and socket. The other 3 are? The other 3 are what type of joint? Hinge joints. Right. Okay. Good. Some disorders. Osteoarthritis, degeneration of joint cartilage and underlying bone, causing pain and stiffness. Alright. Cause for osteoarthritis can be wear and tear, injury, aging, obesity, can be infection also. Whatever is the cause, osteoarthritis is degeneration of joint. Osteo is also there, bone, and arthrosis, arthra, that is joint. Both inflammation of bone and joint. So there is degeneration of joint cartilage and the underlying bone. Osteoarthritis, age related mostly. Then we have rheumatoid arthritis, chronic inflammation of joints leading to pain, swelling and potential joint deformity. Rheumatoid arthritis characteristic is small joint pain. Small joint. The person will start wake up with pain in the joints of the hand, fingers. and the foot. Hand and foot pain will be very common. Autoimmune disorder where the immune system attacks joint tissue, that is rheumatoid arthritis. Then we have gout. What is the cause for gout? Uric acid crystal deposition. Accumulation of uric acid crystals in the joints causing severe pain, swelling and redness. Cause is elevated levels of uric acid in blood, often due to diet, genetics or kidney problems. Metabolism doesn't happen properly, excretion may not happen properly, excessive production might be happening. Whatever is the reason, uric acid accumulation in the joint space is gout. Ankylosing spondylitis, chronic inflammation of the spine and sacroiliac joints leading to stiffness and fusion of the vertebrae. What type of joints are vertebral bones, vertebral joints, intervertebral joints? They are cartilaginous joints. They are not supposed to be fused. They are not supposed to be fused, but spondylitis, ankylosing spondylitis is when the inflammation eventually leads to the fusion of the vertebral bones. Again, it can be because of autoimmunity. Here, you might have seen people with neck stiffness. They will not be able to move their neck. Cervical spondylitis, spondylosis, spondylitis. It's fixed. They will move like this. They can't turn their neck. They have to turn their head. It's painful. People will learn. Whatever happens, everybody has the ability to adapt and become functional. There will be pain, there will be discomfort, everything, but they will adapt and be functional. Bursitis. Bursa means what? Bursa is any fluid-filled space. Bursa is a fluid-filled space. Okay? Inflammation of the bursa, fluid-filled sac, that reduces friction between tissues, causing pain and restricted movement. Repetitive movement, overuse or direct trauma to the joint can cause bursitis. Okay. Tendonitis is again associated with joints only, happening around the joints. It is inflammation of tendons. Tendonitis is inflammation of tendons, causing pain and tenderness around the joints. Cause repetitive strain, overuse, injury. Without training systematically, you go and do super workout in the gym, do excessive weight training, without having acclimatized to weight training, lead to tendonitis. Dislocation, displacement of a bone from the joint space. If the bone is displaced from the joint space from its normal position, it is called dislocation. Trauma, falls or impact injuries. It can be due to injury or any impact. Sprain is what? Generally, sprain is referred to stretching or tearing of ligaments leading to pain, swelling and reduced joint stability. If injury is to the ligament, what will get affected is stability of the joints. Alright, people with knee joint injuries, knee joint ligament injuries, very dangerous. They will just be walking and suddenly the knee gives way and they will fall. Have you seen somebody like that? Suddenly you will see knee, imagine what will happen, like has anybody come and given you a push in your popliteal fossa when you are standing? You are standing and they will come and do this to you. What happens? Suddenly you lose balance and you fall. If you are doing something else and if you are not conscious about what they did, you will fall, lose balance. Imagine that happening spontaneously, just like that. Okay. Frozen shoulder. Have you heard about something called frozen shoulder? People might tell there is frozen shoulder. Capsule stiffness, capsule inflammation. Stiffness and pain in the shoulder joint leading to restricted movement. It is called adhesive capsulitis. Inflammation of the capsule around the shoulder joint. That is frozen shoulder. Often idiopathic but can be associated with injury, diabetes or prolonged immobility. Idiopathic means what? Happens without any known cause. Can happen just like that. Nothing happens just like that. Idiopathic means nothing, we are not able to explain it, attribute it to a particular cause that we know of or we can attribute it to. Carpal tunnel syndrome. Carpal tunnel syndrome is very commonly found in sportsmen or even people who ride too much can have carpal tunnel syndrome. Okay? You should not put yourself in that situation. That doesn't qualify for carpal tunnel syndrome level riding. Alright? All of you know we are riding too much. What if I develop carpal tunnel syndrome? It is like while studying psychology, students feel they have all the psychiatric diseases. Because what is abnormal mentally is going a little over what is normal. Correct, no? Anxiety is normal. Feeling low when you are sad is normal. Continuing to feel low and stay low is depression. Alright? Everybody will feel ups and downs. Feeling elated and happy, feeling excited is normal. Feeling hyper excited for no reason and behavior changing drastically because of that is mania. All of us are sometimes happy, sometimes sad. But if it happens without attributable causes and it is unjustified, then you have a bipolar disorder. Mania followed by depression, or depression followed by mania. You'll feel, you'll see, it's very sad and suddenly they'll get up and say, come on, we'll do it now. That is normal. So when you read disorders of the mind, you should just read it to understand and not correlate it with anything about yourself. Alright? You should leave the diagnosis of a disorder to the expert. You Google and read the list of common behavioral disorders. You will feel 8 out of 10 disorders you only have it. Alright? So you should not do that. You should only do it for understanding and not for diagnosing your own conditions. Carpal tunnel syndrome is the compression of the median nerve in the wrist causing pain, numbness and tingling in the hand. Okay. There is a tunnel. All of these, there are tendons, ligaments and so many nerves, vessels, everything going in this one narrow band, narrow region, which is covered by a cartilage, which is covered by a connective tissue sheath. So the passage through which all of this pass, it is referred to as carpal tunnel. Tunnel is something which goes underground. This sheath that is there here is appearing like a tunnel. So it is called carpal tunnel. Compression of the structures within the carpal tunnel will lead to compression of the nerves that is passing into the hand. So any nerve compression or nerve damage or injury will cause you to experience symptoms related to the nerve conduction. Tingling, pins and needle sensation, loss of sensation, all of those are common things. So repetitive hand movements, wrist injury or underlying conditions like diabetes or arthritis. That is why when you are doing weight training, you will normally stabilize a few joints. You will stabilize this joint, you will stabilize this joint, you will put some support for the wrist joint, you will put some support for the knee joint, you will put some support for back. You will use those protective gear. It is not a sign of weakness or it is not a sign of low strength to use protective gears while doing weight training. You have to use protective gears. Whenever you are doing something that will that will exert your back muscles, your vertebral column, you should use that support. You should use wrist support always, at all times during weight training. Knee support at all times during weight training. Okay. Your intention is to strengthen. A diagram showing axon terminal and synapse is given. Identify correctly at least two of A to D. You identify A to D first. What is A? What receptor? What receptor? Postsynaptic receptor. It is a postsynaptic receptor. B is neurotransmitter. I'll zoom it a little bit more. What is B? Is it pointing to the neurotransmitters? B is synaptic vesicle, not synaptic but synaptic cleft. B is synaptic cleft. Cleft is the space between the presynaptic neuron and the postsynaptic neuron. Then what is C? Look at this. Here C is pointing to one neurotransmitter. D is also pointing to one neurotransmitter. So we should assume C is referring to this whole thing, which is synaptic vesicle. Synaptic vesicle. D is neurotransmitter. Based on this, what we have identified already, we will try to see which one is correlating properly. A is receptor, correct? C is synaptic vesicle, correct. B is synaptic connection. What is synaptic connection? We don't label anything as synaptic connection. So this is wrong. D is potassium ion. That is also wrong. See, in this we will limit our discussion to synapse today. Tomorrow we will again take it up with elaborating a little bit on nerve conduction. When we study nerve conduction, we will have to do muscle conduction also. A muscle contraction, nerve conduction are intricately related. So if we touch upon that, we have to cover both of it together. Okay? How nerve conduction happens, how depolarization, repolarization happens, how the neurotransmitter impacts the muscle, and how muscle contraction happens. This much cycle we have to complete. Neurotransmitter A, B, synaptic B is synaptic cleft. This is correct, but neurotransmitter is wrong. Neurotransmitter is not C, D is neurotransmitter, D is given as calcium. So it's an easy choice. There is no confusion here for you to make your choice. What is a synapse? See, for regulating the functioning of the entire body, you have nervous system being spread out in the entire body in the form of nerve endings. Nerve endings. Nerve endings are terminal parts of axons or dendrons. If the nerve ending has a terminal part of dendron, if the nerve ending has a dendron, what kind of nerve is that? What kind of neuron is the nerve is that if the nerve has dendron at the end? What is the building block of the nervous system? What is the building block of the nervous system? Neurons. Neurons. Neurons are divided into three main parts. What are the three parts of the neuron? Cell body, dendron and axon. What is the job of the dendron? Cell body, dendron and axon. What is the job of the dendron? Receive input. What is the job of the axon? Transmit impulse, carry message away. What is the job of the cell body? It is the processor. If you consider this nervous system as a signal receiving, processing and instruction giving unit, it is a system which will get input about the surroundings, input about the environment, internal as well as external environment. It will process the input and give out output in the form of instruction. That's all. No? It is like the control room. Nervous system is the control room which will get information about what is going on. It will process the information and send signal on what needs to be done. Send information on what needs to be done. Correct? So receiving signal is happening by dendrons, passing instruction is happening by axons. Neurons therefore become three types. Sensory neurons, that is which receives the sensation. Sensory neurons, whose primary role is to receive information from outside of itself, that is from the surroundings or from the internal organs of the body. Motor neuron, or which will carry information to the organs to perform actions, which will carry instruction. Sensory, motor, and neurons which will pass information between neurons. Those are called interneurons. Three types of neurons based on what thing is connecting to the outside. If the receiver is connected to the outside, then it is a sensory neuron. If the instruction is going to the outside, then it is a motor neuron. If the neuron is connecting between the neurons, it is receiving information from one neuron and passing information to another neuron, then it is a interneuron. Receiving information from the periphery, passing information to the center. Center is the cell body. What type of neuron is this? Sensory neuron. Receiving information from the neuron, passing information to the periphery. Motor neuron. Motor neuron. Bundle of neurons, you call it as nerves. If I say nerve is a bundle of neuron, it would be wrong, because nerve is always present on the outside of the central nervous system. Central nervous system is brain and spinal cord. Nerve is what is outside of the central nervous system. That is outside of the brain and spinal cord. That means nerves are those which are distributing wires to the rest of the body, outside of brain and spinal cord. So, cell body is the processor, central nervous system is the processing unit of the nervous system. That means what? Cell bodies of all neurons are present either in the brain or spinal cord. No neuron in the body has its cell body outside of the brain and spinal cord. Clear? That means what? If the nerves are present all over the body, what part of the neuron is absent in all the nerves? What part of the neuron is absent in all the nerves? Cell body is absent in all the nerves. None of the nerves have cell bodies of neurons. Nerves are bundles. Nerves are bundles. They are not one neuron, they are bundles. So bundles of what? Nerves are a bundle of what? Nerves are bundles of axons or dendrons, or it can be both. If there are nerves which are a bundle of axons, what kind of nerve is that? It is a motor nerve. If the nerves are a bundle of dendrons, it is a sensory nerve. If a nerve is a bundle of both, axons and dendrons. It's a not internerve, it's a mixed nerve. Alright. So nerves, 3 types of neurons: sensory neurons, motor neurons, interneurons. 3 types of nerves: sensory nerves, motor nerves and mixed nerves. Is this clear? Sensory nerves, motor nerves and mixed nerves. Now all of these should keep passing on information between each other. Correct? So if the neuron is receiving information, neuron is passing on information to the interneuron. How does it pass information, how the information passes from one neuron to another neuron? Synapse, junction. Now, there are 2 types of junctions. Neuron is passing information to another neuron. There is a junction between the 2 neurons. Neuron is passing information to a muscle to contract. There is a junction between neuron and muscle. So there are 2 junctions with which neurons are associated. One is a junction where 2 neurons are communicating with each other. Another is a junction where a neuron and a muscle is communicating with each other. The junction between 2 neurons, you call it as synapse. What do you call the junction between a neuron and a muscle? Neuromuscular junction, NMJ, neuromuscular junction. Alright, neuromuscular junction. What kind of signaling has to be done? Now there is signaling being passed on. Every function in the body is happening because of these signals. Every function in the body is happening because of the signals being passed between neuron and neuron, neurons and muscles or glands. So predominantly the neuronal signaling is happening via chemicals. The messaging is happening via chemicals. A particular chemical is capable of stimulating a particular response in the effector organ. Effector organ is what is being acted upon. A particular chemical is capable of stimulating a particular kind of chemical being produced in another neuron. So these chemicals which are being used for communication between neurons and between neuron and muscle is called, these chemicals are called neurotransmitters. Neurotransmitters. There are hundreds of varieties of neurotransmitters that the neurons can produce. There are hundreds of neurotransmitters the neuron can produce. There are proportionately so many more types of receptors on which these neurotransmitters can act. Based on who is communicating with whom, where the communication is happening, what kind of action needs to happen, there will be different types of receptors at the junction. So in a junction of communication between 2 neurons, we are talking about synapse. So we will talk about the junction of communication between 2 neurons. What all need to happen at the junction where 2 neurons are communicating? First of all, there should be the 2 ends of the communicating neurons coming closer to each other. Yes. Should they touch? They should not touch. If they touch, then the communication will become more continuous. It should be controlled communication. So they should be closer to each other but not touching each other, so that there is a junction formed. And this junction we call it as synapse. So there is a space in the synapse. We call that as a cleft. Synaptic cleft. So there is one neuron which is before the synapse, before the junction, and there is one neuron which is after the junction. The neuron which is before the junction is called presynaptic neuron. The neuron which is after the junction is called postsynaptic neuron. All the neurons are capable of producing neurotransmitters. Now whatever neurotransmitter is produced by the neuron, presynaptic neuron, has to reach the synapse. So after production, the neuron will package this neurotransmitter into membrane bound pouch. What do you call a membrane bound pouch in a cell? What do you call a membrane bound pouch in a cell? Vesicle. Now this is a vesicle. This is a pouch. Vesicle. These are also vesicles only. This is opened up, that's all. These are all opened up to show you there is neurotransmitter inside that. Here it is vesicle coming down. The vesicles carrying neurotransmitters to be delivered where? To be delivered at the synapse. So what do we call this? We call it synaptic vesicles. Synaptic vesicles. Neurotransmitters should be produced. Neurotransmitters is packaged into synaptic vesicles. The vesicles have to be delivered to the synaptic membrane. This is the neuron, presynaptic neuron. The membrane is here. There is a membrane here at the end of at the synaptic knob. That is called the presynaptic membrane. This is another neuron on this side, postsynaptic neuron. The membrane facing the synapse will be called postsynaptic membrane. So at the presynaptic membranes, the neurotransmitter has to be released. On the postsynaptic membrane, what do you need to have? Receptors. Now this presynaptic membrane will be of an axon of the neuron, of the presynaptic neuron. Correct? Axon of the presynaptic neuron is forming the presynaptic membrane. On this side of the postsynaptic neuron, what process will be associated with the synapse? Dendron. So synapse is between an axon of the presynaptic neuron and the dendron of the postsynaptic neuron. Question. This understanding will be explored in questions. Alright, it is not between two axons or two dendrons. It is between a dendron and an axon. Alright. So all the components are there. How the neurotransmitter is produced? When a signal reaches a neuron for the production of a particular neurotransmitter, the neuron will start producing neurotransmitters. How it produces and all that we will see. Neurotransmitters that are produced are packaged into vesicles. The vesicles are transported through the intracellular transportation mechanism to the presynaptic membrane. At the presynaptic membrane, the vesicle will fuse with the presynaptic membrane. Vesicle fuse to the presynaptic membrane and it opens up into the synapse, releasing the neurotransmitters into the synapse. What is the mechanism by which this is happening? What is the process called? Where a vesicle comes from inside of the cell, fuses with the membrane, releases its contents outside of the membrane. What is this process called? Mechanism of cellular transport. The reverse is also possible in cells. There is something outside, cover it up with membrane, fuse it with the membrane, push it inward. This is a pouch being pushed, fused with the membrane and the contents being pushed outside. This is one transport mechanism across the cell membrane. Yeah? Come on. Different ways of moving material into and out of the cell. You can do it through channels, you can do it through pathways, you can do it through membrane bound transport. This is membrane bound transport. What type of membrane bound transport is this? Where a membrane is fusing with membrane pouch is fusing with the cell membrane and pushing the contents outside of the cell membrane. Plasmolysis. What does it mean? Breakdown of something. This is not. What do you refer to something which is inside? What? Give me two opposite words. One referring to something being inside and one referring to something being outside. Endo and exo. This is a transportation of material from inside cell to outside of the cell. So this is exo. What exo? Exo what? Exocytosis. It is exocytosis, isn't it? You should correlate, you should link one to the other from here to there. When you see this, it should strike in your mind, oh, this is exocytosis. Alright? By exocytosis, neurotransmitters are pumped out or pushed out into the synaptic cleft. In the synaptic cleft, the neurotransmitters will go and bind to the receptors on the postsynaptic membrane. Neurotransmitters will go and bind to the receptors on the postsynaptic membrane, which will initiate depolarization in the postsynaptic membrane, causing further reaction, whatever needs to happen in the postsynaptic neuron to happen. Alright? Is it clear? So just by looking at the diagram, not doing anything else, two neurons have to communicate. How will they communicate? They have to communicate chemically. That means one neuron is producing some chemicals which will send some message to the other neuron. How will the chemical from this neuron reach the second neuron? If the second neuron is receiving chemicals, how do we know that it will respond to this chemical only? Receptors. Design, purpose, design, function. Purpose, design, function. Very powerful tool that is. Alright. So we'll run through some of the notes that I have made for this for you to understand. Okay. What is a synapse? A synapse is the junction between two neurons or between a neuron and a target cell. Between a neuron and a muscle also can be referred to as synapse, but it has a specific reference, neuromuscular junction, where the transmission of electrical or chemical signals occurs. It is the point of communication between cells in the nervous system. Where is the synapse present? Throughout the nervous system, including the brain, spinal cord and peripheral nervous system. They are found at the end of an axon of one neuron connecting to the dendrite cell body or axon of another neuron or to a target cell in the muscle or gland. Okay? Function of synapse. Primary function of a synapse is to allow neurons to transmit signals to other neurons or to target cells. This communication can be excitatory, meaning what? Stimulating the next cell to fire an action potential, or inhibitory, preventing an action potential in the next cell. So when we talk about excitatory neurotransmitters and inhibitory neurotransmitters, okay, it means, are they stimulating depolarization or are they preventing it? Are they exciting it in terms of firing an action potential or bringing it down, prevent it from that? So we discussed this, presynaptic neuron, synaptic vesicle, synaptic cleft, postsynaptic neuron, neurotransmitter receptors. What are neurotransmitters? Chemical messengers that transmit signals across the synaptic cleft from one neuron to another or to a target cell. When an electric impulse here is an action potential. Tomorrow we will see mechanism of nerve conduction we will study, because this is giving us an opening for studying that. Along with mechanism of nerve conduction, neuromuscular junction, muscle action. All these three, if we finish tomorrow, that will be a good completion. When an electrical impulse reaches the end of a presynaptic neuron, it triggers the release of neurotransmitters from synaptic vesicles into the synaptic cleft. These neurotransmitters then bind to specific receptors on the postsynaptic cell, causing their either excitation or inhibition of that cell. Same things that we already discussed. Classification of neurotransmitters. Questions come on this. What type of neurotransmitters are so and so? What is it? What type of influence does it cause? Which one is excitatory? Which one is inhibitory? Such questions do appear. So I have given you a table to know that. Type amino acid neurotransmitters produced in the central nervous system. Excitatory action, glutamate promotes action potential in postsynaptic neuron. Amino acid neurotransmitters. GABA is gamma amino butyric acid. GABA prevents action potential in postsynaptic neuron. So GABA is an inhibitory neurotransmitter. Glutamate is an excitatory neurotransmitter. Monoamines produced in the brainstem, dopamine and serotonin. Dopamine is an excitatory neurotransmitter. Serotonin is an inhibitory neurotransmitter. Dopamine can have excitatory effects related to reward and motivation. Serotonin can have inhibitory effects, especially in mood regulation. Norepinephrine is also functioning as a neurotransmitter. Norepinephrine is noradrenaline. Generally excitatory, increases alertness and arousal. Okay. Dopamine is also referred to as happiness hormone. It's a happiness hormone, neurotransmitter, produced when you are happy. When your parasympathetic stimulation happens. When the parasympathetic nervous system is stimulated, dopamine is produced. Dopamine is a neurotransmitter in the parasympathetic nervous system. Epinephrine, serotonin and all, serotonin is the neurotransmitter in the sympathetic nervous system. Inhibitory neurotransmitter, makes you feel low. Dopamine makes you feel happy. Alright. So doing exercise increases dopamine. Thinking positive thoughts increases dopamine. Okay. Dopamine, oxytocin, these are all associated with happiness. Then the next type of neurotransmitters is peptide neurotransmitters produced in both central and peripheral nervous system. Substance P is an excitatory neurotransmitter involved in pain perception. Endorphins are also pain reducing neurotransmitters, act as natural painkillers, induce euphoria by inhibiting pain pathways. Endorphins are released when you decide to endure pain. See, you will have pain, you make a choice not to experience that pain. Endorphins are released. Endorphins will make you increase your pain tolerance or better tolerate pain. It also gives you a feel good factor, endorphins. So endorphins and dopamine associated with happiness. Purines produced in CNS and peripheral tissues. ATP can act as an excitatory neurotransmitter. Making you perceive pain. Adenosine, typically inhibitory, plays a role in promoting sleep. See, the same metabolic substances that we talk about, they can function as neurotransmitters also. The chemicals, they have multiple roles. It is not one role that they are participating in. They have multiple roles, multiple functions in multiple places. Acetylcholine, very important. Acetylcholine will give you questions. Neuromuscular junctions. Acetylcholine is produced in neuromuscular junctions and the CNS. Excitatory at neuromuscular junction promotes muscle contraction. There is a disease where the enzyme which is supposed to break down acetylcholine will be deficient. So acetylcholine will continue to remain present in the synaptic space, causing continued stimulation of the muscle, twitching of the muscle. What disease is that? Huh? Spasm, no. Spasm is not a disease, yeah. That promote the firing of an action potential in the postsynaptic neuron or stimulate a response in the target cell. That is excitatory action. Inhibitory action is opposite of that. It will prevent action potential to be developed. Alright. Okay. Next question also is related to special senses. Eye. Too much of loading, too many concepts, a lot of discussion, a lot of things will be discussed. Alright. We will take up eye in the next class. Any question? Any question anybody has related to whatever we have discussed today? Do you remember the structure of eye? No. If you are light, if you are a particle in light and you have come here, what all will you cross before you reach the retina? Can you tell me that? What is the first thing that you will hit? Cornea. Okay, then you cross the cornea, where do you end up? Iris. There is a space between cornea and iris with fluid in it. Aqueous humor. Aqueous humor. Then you will not reach iris. You will reach iris. If you hit iris, you are not allowed entry. What should you cross to enter into the eyeball? You should go through the door. What is the door? Pupil. So you cross the pupil, then what do you encounter? Lens. After you cross the lens, vitreous humor. Vitreous humor. Then you go on to hit the retina. You go on to hit the retina. Okay. From outside to inside, there are three layers. Eye is like a three-layered softball. Eyeball is like a three-layered softball. The outermost layer is the sclera. The middle layer is the choroid or the vascular layer, and the inner layer is the retina. So you look at it from outside to inside, you have three layers, coverings you can say. But if you look at it functionally, you have regions: anterior region, middle region, posterior region. It is not exactly one third. The posterior region is bigger part. The anterior region, middle region and posterior region. Anterior region you will have light reception and light regulation components. In the middle region you have lens manipulation and fluid formation components. In the posterior part you have retina. That's all. So we will elaborate on all of this tomorrow. Alright. We will end for the day. Any doubts, any questions, any clarifications, please do ask. Otherwise we will break for the day. Two things I want you to take, just realign yourself. One is the habit of jotting down things. The habit of jotting down whatever you feel is important. Whatever you feel has to be reinforced. Then the other one is transferring that to your notes as appropriate. Alright. Okay. Right.